It leaves you having reduced your field of healthcare provision. And I don't think we should ever cut anything out of physical therapy at all, particularly at the behest of another group. I think we should keep it as this containment. Now, that doesn't mean that I think all physical therapists should do all procedures. I mean, if somebody came to me with cerebral palsy and asked for me to do the Bobath procedure, I would be totally incompetent to do this. I shouldn't do it. I should try and find somebody that knew about this. I mean, I could do reflex inhibiting postures and so forth for perhaps a day while I kind of found somebody else to take this over. I mean, I could probably make a bit of an effort, but it would be incompetent. And I think that we should be handling these matters of competency not by letting others say what we're doing, but doing it within ourselves. And if people exceed the levels of their professional competency, that is non-professional conduct. And they should be dealt with within our group for doing things outside the level of their expertise. And so I think that the synthesis that we've developed means that all of this is in the bounds, certainly, of your expertise. And so that will be what we're going to try and do over the next 6 days. Now then, what kinds of strategies can we use so that you're not listening to my English accent and Anne's English accent, and Chris's Dutch English accent, and Anne's American accent, okay, for 6 days? Well, I think with a group like this, and the knowledge that you have, it seems to me a very good thing that we should try and pull from your brain stuff that you've had previously, because it will create a few more of those little communications that occur between grey matter, make it a little bit more readily available to you. So we should use that, and I'd like to use that in single little exercises that we do, and also in group exercises that we do. I'd like to just mention to you a technique that we've used quite a lot in the past, and I've always found it very useful, which is a technique that was developed by a British communicator called Buzan, who wrote a very nice little book on mind mapping. And what he suggested, and Dave has very thoughtfully placed in your folders blank sheets of paper. Because Buzan feels that we shouldn't be trying to get stuff out of our brains in a sequential way. And lines make you go sequentially. We should try and bring information out in a random fashion. You know how sometimes you're doing something and something jumps into your mind, a completely different thing that you couldn't remember an hour before? Well, our brains compute things in this sort of fashion. And so to enhance this particular capacity of the brain, he suggests that we should use a thing that he calls mind mapping, where we start with a central theme like this, which could be, say, neuromuscular skeletal dysfunction, and we start thinking to ourselves, and let's say we say that we will deal with just the lumbar spine here. What we would do then is to start thinking about what are the stuff that we use, and what are the things that we know related to this. So I could perhaps start by thinking in terms of the anatomy. All right, I'm not going to do a full one because you can do these as we go. And then I think about the anatomy, and I can perhaps think of movement coupling. If I think of movement coupling, this brings me into the whole problem of non-congruent and congruent movement. And how do we use that? We use it for getting very specific movement at a particular segment. I could then think of the anatomy from a slightly different point of view, let us say. And I could think of angular movement, and I could think of translation movements, like this. And if I think of translation movements, it brings into mind the principles of, say, hysteresis. And if I'm thinking of this and the combination of that, it takes me into thinking about perhaps hypermobility and instabilities. And while I'm thinking about hypermobility, what comes into my mind might be something like generalized hypermobility. And when I'm thinking of generalized hypermobility, I might think of this within normal limits, or I might think of it in terms perhaps of syndromes such as Marfan's syndrome or Ehlers-Danlos syndrome, which are all particular forms of collagen problems. And so, what we're trying to do is to get these sheets of paper so they're just one mass of kind of ideas, just as your brains went, to produce all of the stuff that you've learned on the courses with the Institute and also other courses that you've done and from your own experience. And this is an inordinately good thing, but you've got to kind of break this tendency to sort of go one after the other, because that sets you along a particular pathway and it tends to close off other files that have important information in. So that when we do this system to totally break, okay, the tendency to think sequentially, we'll actually use the paper sideways on like that. Not this way, okay, but we'll use it sideways on like that. And then we'll see how that particular thing works. What Buzan found was that at the end of a, say, 45-minute session, and he feels that that is the maximum that you should do, and then have a little break for active recall, that your active recall should follow of this previous half hour or 3/4 of an hour, should follow this plan. And at the end of the day, if you just look over that plan and just spend a few minutes thinking about it, you'll find that your recall levels are much higher. These sad statistics you find after 3 days, that the stuff you learned 3 days previously, you only remember 20% of it. That means that we could all go home at 11 o'clock this morning. I mean, that is a sad reflection. And so what we need to do is to really, really support our memory systems. Now, we can do it, of course, by theory. We can do it by these kinds of systems. We can augment it, certainly, by practical stuff. So we've got this kinesiological input of what we're doing. We'll try and use some sort of video things that I've brought along, and we'll try and see how these go in terms of just 3 aspects. There's a little video that I made of like a review of the whole of muscle energy techniques, which takes about an hour and a bit. And if we've done all of the techniques, you can sort of spend and you can do a little mind map as this thing just runs through the whole of this. If we have a consideration, let's say, of anterior knee joint pain, I've got a tape that was made by Jenny McConnell that we could look at. It takes, about an hour and a little bit. So you can actually see her working with some of these knee joint pains and the emphasis that she makes on some of these things, which we can add to what we're doing. So we can use that kind of thing to recall stuff. So there's a lot of ways that we can try and enhance our memory patterns. But this I found to be an inordinately useful kind of system. Now, when we get to these kinds of courses, we try to make the things much more complete. One of the problems I'm sure all of us deal with all the time is this joint that's causing the pain the major problem? It's the source of the pain, but is its reaction from somewhere else? In other words, this might be the victim. Where is the culprit? And the more advanced we get, the tendency becomes to start looking more globally at the body with its complicated meanings when we do this. Because sometimes the time, certainly in the way that we have to work for our $22 or whatever we get Canadian, we have to sort of move very fast and see lots of patients in a day. That's the problem. So we tend to sort of try and look globally, but I know that very often the system makes us more focused on the particular active problem at the time. Now, you might have to start doing this as well, with the way that your system is going to be modified. Who knows what it will mean? I don't know. Nobody knows, do they? But if you look at other systems in the world that took up government-based plans, you find that everybody starts to work longer days, shorter times with the patients, and so on. I don't know that that's any particular detriment to the patients, to tell you the truth. I think you can sort of mess about with some inconsequentials sometimes when you've got to fill up perhaps an hour. For example, in the Norwegian system, they have to see everybody for an hour or something. And it's split up into 3 or 4 phases. They've got to have a certain amount of physical agencies, such as heat or cold or something like this. And then there's a certain amount of time built in for examination. Then there's a certain amount of time built in for whatever procedures you're going to do. And then there's a certain amount of time built in to go over the particular home exercises that this patient's got to do. And so every treatment results in that. Now, Cyriax used to be very, very disparaging about things like this, in the sense he used to say, what is the point of trying to teach a person quadriceps exercises if they have got a tear in a meniscus? Because every time they do the quadriceps exercise, it hurts them, so they get inhibition. And also, this displacement within the joint is probably creating a certain degree of effusion, which also gives inhibition. So what is the point of this exercise? The point he used to make was to alter the position of the displacement and restore it to its normal position. Now, giving all these other things of home programs and all that, in that particular case, would be pointless. So I think we've got to sort of do this fairly carefully when we think about, should all patients have this amount of time? Some of the things, when you only do 1 or 2 procedures, require the utmost skill. But in our system, you get far more money for putting a hot pack on someone for 20 minutes than you would for doing a manipulation of, let's say, C1-2, which requires a tremendous amount of thought and assessment. You know, that's the stupidity of some of these kinds of systems. So, when we look globally, we have to kind of be a little reasonable. I was looking at the tapes of the lower quadrant course done by Earl. And when I look at some of these things, I'm really amazed at my colleagues and really gratified that I am a member of their group. I sort of enjoy their thought processes. I respect their thought processes. And I realize sometimes that I perhaps should change sometimes the way I teach, because I look at my colleagues and I think, I'm not doing that, or I'm not emphasizing that, and it should be emphasized. On the other hand, I look at this and perhaps another part and think, no, they're not emphasizing that as much as I would, and I think they should. And I think this is what's so nice about you being able to look at different instructors and to go through the tapes, which are all very excellent, so that you have a composite, not just of this course taught by me and Anne and Chris and Anne and so on, but a course that's taught by another instructor who's got similar but sometimes slightly different ideas and emphasis. And that's really nice. And if you find that there are differences in opinion, differences in fact, I mean, there can't be any differences in fact, but in the theory, okay, that perhaps means out there that either one or the other of us should be sort of thinking a bit more carefully about this, or that perhaps the knowledge isn't out there and we are theorizing. And I think when we theorize, we should let you know this, that this is not fact, but if you teach it twice, you tend to be teaching it as fact. And I'll try and avoid that. I mean, there's some stuff I was looking at just before coming down here, because this is one of the reasons I teach, because it forces me to keep my reading up. You kind of look at books like Kapanji and you see that, in dorsiflexion of the foot, we get medial rotation of the fibula. You look at Gray's Anatomy, who describes it perfectly well as giving lateral rotation of the fibula. We look at Capandji and our theorization and see that perhaps on dorsiflexion we get an upward movement of the fibula. Dave Reed gave me an article from a very obscure journal of 1970 which shows that the initial movement of the fibula is downwards, and the whole article described beautifully the way that kinetic and stored energy is responsible for a lot of these processes. So where are we with a lot of these things? There's theories out there and there's various procedures that are done, and very often I think what we find is that if we can restore movement, if we can stabilize hypermobility, then a lot of things will take care of themselves without us necessarily always knowing exactly what should happen and getting tied up with this because you follow this particular anatomy book or that particular sort of theory of kinesiology. And I'll try and sort of be fairly open with those ideas. Now, I'm not going to do quite as much as Earl did on walking. When we look at the movement of the spine in terms of Cyriax's scan, okay, there is the basic scan. And I'm going to be interested to see what you think that the basic scan should consist of. I asked people in Canada to do this a little while ago on a muscle energy course. This whole process took about an hour and a half. I was seeing all kinds of tests being done, and at the end of them I said, what was your criterion for actually following that route? And I was really disappointed when nobody knew. They just did all of these tests. Cyriax used to say that you can over-test people. What is the point of going through all kinds of tests for instability, for example, if there's no evidence that instability is there? We've got to have certain points along this pathway that we're following that shows us that we've got to take the left fork. But if the sign says go right, then we should just go right and not take the left fork with all the ramifications of doing this. So we need to sort out, I think, this morning, an algorithm, a flow chart from you in a group as to why you would do certain procedures. And then on this particular course, we'll go over refining these procedures as the best we can to see where you go. But in any particular examination, we need to know when to select that group of procedures and when to select this group of procedures. That's really very important. Now, one of the things that Earl was mentioning, and it's beautifully illustrated on the tapes that David has of the lower quadrant, is the enormous conservation of energy that is related to this action of human walking. How very little muscle work has to be done when a person is walking on the flat. Now, this might be a very useful way, of course, of looking for where the culprit might be if we've got backache, if we watch a person walk. Now, one of the things I think is really important is that in my particular setup, having patients walk in my little clinic is not really all that great. I would definitely have to have some kind of a treadmill to watch them walk reasonably well so that I could keep them in place. The other thing is that if you are trying to assess a walk and you're trying to assess where stiffness is or where hypermobility is, sometimes you don't want the patient moving away from you. And if you're sort of struggling behind them trying to do various things, it's somewhat loss of dignity, and perhaps the way that you're moving confuses you too. Now, I was really interested on the last exam that we did with Dave Reed, who is one of our examiners in Edmonton. This fellow was asked to talk about the arthrokinematics of the foot. And he went through all of the movements that the talus does and the cuboid does and the cuneiforms do and everything like this. And this took about 10 minutes, and he really sounded very knowledgeable on all of this stuff. And there's Reed sitting there, and he said, let me tell you something. He said, where did you get all that from? And this guy said, well, this certain book. So Reed says to him, well, that's what kind of theories you come up with if you're a podiatrist. He said the whole world for podiatry is the foot. He said for the rest of us that look at the body, perhaps walking doesn't take place from the foot. The foot just happens to be part of walking. If you go with Grotowski and the spinal engine, walking doesn't really require the legs. It really requires the legs only to keep the trunk high off the floor. This is the communication with the floor. And that the walking action comes from the trunk. And what happens in the foot happens because of the dynamics of what's happening as the line of gravity changes. There's certain things of control, for example, within the foot, where we don't want the thing flapping around like this, so we've got muscles that lower it to the ground. Then we've got muscles that can, as the weight gets taken over it, control some of the ways that the forces are placed through the foot. But we know very well that when a person stands fairly still like this from electromyographic studies, there's no particular muscle action taking place in the foot. It's done by the shape of the bones held together by the ligaments. And there are certain ligaments which we can do when we do the foot, which have got particular actions, such as the plantar fascia, which can wind the foot up and elevate the arches just by a passive action. So I think we've got to be a bit careful with, the way that we theorize this, that certainly walking, I suppose, starts from the brain. But where does the energy come from? It's whether we think of the world starting from the feet or whether we take it some other way. But when we look at walking as this very useful action, that the trunk produces some sort of an energy to get the hip forward, and Farfan always used to talk about walking being a controlled form of falling. That we get going forward like this, and if I didn't get my leg out to stop this, I would fall over on my face. So I've got to have that perfect timing, that as my body weight goes forward and my line of gravity is now in front of the base of the other leg, that this foot lands down. And I'm just changing the action from one foot to another. But for this to happen, we need a lot of things happening correctly. We need to have reasonable movement of flexion and lateral rotation in the hip. We need to have reasonable movement of posterior rotation of the ilium. And on the standing leg side, we need to have reasonable extension in the hip and reasonable anterior rotation of the ilium. Because if those are missing, we're going to start having to compensate somewhere else. If we take this down a level now, to the knee, for example, if I cannot get my knee straight for a variety of reasons, let's say I've got very tight hamstrings, let's say that I've got tight gastrocnemius complex, that I cannot fully straighten my knee, what happens now is that that normal locking mechanism of the knee, which is an extremely efficient ligamentous system that doesn't require muscle, now as I go through, I've got to use the quadriceps muscles constantly. They're not built to do that, and I start to get all kinds of problems with some other mechanism that would compensate for this. Or I start getting problems within the knee itself because of these compression elements that go on. If I can't get through sufficiently far with dorsiflexion of the ankle, I've got to break that movement very quick to get my leg out because I just can't go forward far enough. Or if I've got some instability of the tibiofibular syndesmosis, so that as the foot comes back it splays the bottom of the ankle, this I may have to compensate with some other system. And so on a course like this, and at the level that you are, because you are the future of this profession, aren't you? And the future is here now. You're the people that have put in the work. That's why I've always got the greatest admiration for all of us, including myself. Have you ever worked out for yourself, sat down with a bit of paper and worked out how much it's cost you in money to get to this level now? Not so much in terms of time and lost time with your families and all this. Have you ever done this? It's frightening. Don't do it. It's frightening. Particularly when you realize that other people in your profession get exactly the same fee as you do without doing any of this. I had a student with me a little while ago, fourth-year student, 1 month to qualification. He knew absolutely nothing. I was really disappointed with him because I've always been very pleased with the students that I've had. This guy really was bad. And I was really perturbed when I thought that in 1 month he's going to have his qualifications and he'll get exactly the same fee for treating patients as I get. And what's more, if I treat them a bit fast and kind of build a system as if I did an hour's treatment and I only did half an hour's treatment, I would be up before the disciplinary committee. He could sort of spend his hour doing whatever he would do. And it really perturbed me. And I must be getting more irritable in my old age. That's why I spoke to this woman in such an unkind way yesterday, I think. So, when we look at this, I think what we're going to have to do with this course is to sort of look at some of these sort of total combinations of movement and see if we can bring them in to our scanning examination. And I think that it's going to be perfectly possible. The two ones that I use more of the time, instead of necessarily, I mean, I look at walking, but not particularly in sort of terms of a particular analysis. I'm just really looking at the efficiency of this as a movement. But I find that I like to keep patients relatively still for me in my little cubicles or something, all right? And so, as well as the scanning examination, one of the things that I use a lot of is a full squat like this, because that picks up a lot of dysfunction, and also a total body rotation, because that brings up quite a lot of things which the person can do, and you can kind of assess it as we go. And I think we could look at what the possibilities are with those things as we develop the scan. So in your notes, I'm not sure which volume it's in, David, we have some of the pictures of primary and secondary lesions and this whole aspect of walking. We'll do bits and pieces of this as we go throughout the next 2 or 3 days and hope that you can write in on any of those things relevant material. Is it in book 1? Yes, I haven't quite got which of the volumes are yet. I'll do that at the break.
The original notes are in
Book
book 1.
1, okay.
And then all the addendums.
Yeah, okay. So book 1 represents the lower quadrant course as would come on Earl's films, and is also taught by Jim Meadows as well. And I've been very happy to sort of get hold of those notes because they have been well done. There's 1 or 2 things that I don't agree with, and I will tell you when we go through these. Okay? Sometimes it's in terms of terminology where we've kind of coined a new terminology, and I think that's very unfortunate. I don't think we should coin new terminology unless it's totally different to whatever anybody else is using. But if it's sometimes the same terminology but a different meaning to other people, it just gets very confusing in terms of our communications. Now, I think that I should give us, yes, I've gone over that magical 3/4 of an hour. So I'm going to give you just a couple of minutes to just think about what I've just said. Anything that you need to write down you can, but generally speaking in an introductory remarks, you know, it's mostly just to let you listen to me and